Chapter 8, Skeletal System, Axial and Appendicular Skeleton, Part 5. So we're moving on to the lower portion of the appendicular skeleton. This is where the pelvic girdle attaches to the sacrum of the axial skeleton. The pelvic girdle, it consists of the right and left os coxae. Os coxae, also known as the hip bone, coxal bone, pelvic bone. We're going to call it the os coxae. So right and left os coxae form the pelvic girdle. They attach to the sacrum. However, the sacrum is not part of the pelvic girdle. We also have the pubic symphysis, the cartilaginous joint that attaches the two os coxae to each other. Then we have the pelvis. The pelvis is the right and left os coxae, the sacrum, and the coccyx. So the bones that help to form the pelvic cavity. So the pelvis is the right and left os coxae, the sacrum, and the coccyx. The false pelvis is the portion of bony material that is basically the inferior part of the abdominal cavity. So it's around this brim and up. The true pelvis is around the brim and down. That is the bony portions that end up making up the pelvic cavity. All right, the os coxae. The os coxae, the hip bone, is actually made of three separate bones that fuse when we're around the age of 13 to 15. Those separate bones are known as the ilium, ischium, and pubis. So we often refer to those three regions of the os coxae, ilium, ischium, and pubis. Also can see a couple of important surface features to the os coxae. We have this big opening called the obturar foramen. And we also have this large depression known as the acetabulum. Acetabulum articulates with the head of the femur to give us the hip joint. All right, os coxae. We'll start with the ilium. The ilium has a long ridge at its top called the iliac crest. Underneath or inferior to the iliac crest is this smooth area known as the iliac fossa, where the intestines would rest, basically. Then we have these two bumps coming out toward the front, the anterior superior iliac spine and the anterior inferior iliac spine. Long names, but basically it's just directions. Anterior toward the front, superior toward the top, iliac, part of the ilium, spine, something that sticks out. Anterior toward the front, inferior, lower, iliac, part of the ilium, spine. We also have this large rough area that is the auricular surface. This is what attaches to the sacrum, giving us the sacral iliac joint, which is a fibrous immobile joint. Then we have a bump out the back called the posterior superior iliac spine. Another bump, the posterior inferior iliac spine. And then we have this notch here called the greater sciatic notch. So posterior superior iliac spine, posterior inferior iliac spine, greater sciatic notch. Move on to the ischium, the more posterior inferior bone. The ischium has a point that sticks out, that is the ischial spine, and then a small notch called the lesser sciatic notch. So posterior superior iliac spine, posterior inferior iliac spine, greater sciatic notch, ischial spine, lesser sciatic notch. The ischium also has a large rough patch referred to as the ischial tuberosity. Ischial tuberosity, way down there, is actually the part of the hip bone that we sit on, as it were, when we're sitting down. Then the pubis, the inferior anterior bone, right and left pubis, help to form the pubic symphysis. The pubis has a superior pubic ramus, which then leads up to the acetabulum, has an inferior pubic ramus, which attaches to the ischium. It has a point that sticks out called the pubic tubercle, and then this slightly rough patch here is the symphysial surface. That is where the cartilage fits in for forming the pubic symphysis. All right, hip dysplasia. Hip dysplasia is a birth defect where the hip bone is displaced from the acetabulum. This could be because of the ligaments in the infant being too loose, could be because the acetabulum has not completely formed yet, but it makes it, impossible for the infant to move its legs properly. You also can see in this great X-ray how the ilium is not connected to the pubis or the ischium. Pretty wild. All right, the female pelvis versus the male pelvis. It turns out this is the easiest way to distinguish a female and male skeletons. The female pelvis has a very wide sciatic notch, has more flared out ilium, has a very wide angle at the pubic symphysis, basically increasing the space for the opening to allow the infant to pass through the hip bones and out of the body. The male's pelvis has a narrow greater sciatic notch, has more narrow and more vertical ilium, and a narrow angle below the pubic symphysis. Again, because the male doesn't need to provide extra space for the head of that infant. Moving on to the femur, or the thigh bone. The femur is the largest bone of the body. It has a large, smooth knob called the head, articulates with the acetabulum of the os coxae. Below that is the neck. Then it has this large, rough patch sticking out laterally called the greater trochanter. Go down to the distal end. There's this smooth area here, which is the patellar surface, articulates with the patellum. Head always faces medially. If you look into the head, you see that there's a little divot. That little divot is called the fovea. That's the attachment site for a ligament. Here's the greater trochanter. Oh, look, there's a lesser trochanter. Looking at a posterior view of the femur, again, we can see the greater trochanter. You can also see sticking out posteriorly the lesser trochanter. Then there's a ridge of bone that connects the two called the intertrochanteric crest. Greater trochanter, lesser trochanter, intertrochanteric crest. There's also this ridge going along the shaft of the femur. This is the linea aspera. Down at the distal end of the femur, we have rough patches sticking out laterally and medially. These are the epicondyles, lateral epicondyle, medial epicondyle. Medial epicondyle, same side as the head. We also have these two smooth rounded knobs at the distal end. This is the medial condyle and the lateral condyle. They articulate with the tibia. And then there's the space between the two condyles called the intercondylar fossa. Again, head is on the medial side, making this the medial condyle and medial epicondyle. Patella, kneecap bone. The patella is got a broader base that is more proximal and a narrower apex, which is more distal. The patella is embedded within the quadriceps tendon. Flip the patella over and it has this smooth surface. Smooth surface is the articulator surface. Articulator surface makes contact with the femur. There are two bones in the leg, the tibia and the fibula. The tibia is the more medial bone. It is thicker. It is the weight-bearing bone of the lower leg. The tibia at its proximal end has a medial condyle and a lateral condyle. Normally condyles are smooth rounded knobs, but in the tibia they are flat. Then sticking out anteriorly between them is the tibial tuberosity. This is where the patellar ligament attaches to the tibia. Then this thin edge on the tibia's shaft is referred to as the anterior border, basically the shin of the tibia. And then sticking downward or proximally is the medial malleolus. Medial malleolus, same side as the medial condyle. And actually, if you touch that bump near your ankle, it's on the medial side, that is the medial malleolus. If we stare down into the top of the tibia, we see that between the lateral medial condyles are these two little bumps sticking up. These are the intercondylar eminence. Intercondylar eminence. And the, of course, condyles of the tibia articulate with the condyles of the femur. All right, fibula. Fibula is the thin lateral bone. It does not bear any weight. The fibula has two important structures. At its proximal end is the head. Head articulates with the tibia. And at its distal end is the lateral malleolus. Lateral malleolus articulates with the talus. Lateral malleolus is the bump near the ankle on the lateral side. There are the tarsals. There are 7 tarsals that make up helps to make up the ankle area. The tarsals' names are talus. Talus is more proximal, articulates the tibia and fibula. There's the calcaneus or heel bone, the navicular, the cuboid, the lateral cuneiform, intermediate cuneiform, and medial cuneiform. I do not have a mnemonic for the tarsals. Sorry. All right, from there we get the metatarsals. Metatarsals come after the tarsals. There are 5 metatarsals named metatarsal 1, 2, 3, 4, 5. The number 1 starts at the same side as the great toe. And then, of course, we have the phalanges. 14 phalanges for the 5 toes. Here is the great toe. So it would be named 1 and 2. So this is proximal phalanx 1, distal phalanx 1, proximal phalanx 2, middle phalanx 2, distal phalanx 2, proximal phalanx 3, middle phalanx 3, distal phalanx 3. So again, 14 phalanges for our 5 toes. The foot has 3 arches. These 3 natural arches of the foot help to support the weight of the body, to distribute that body weight in the most ideal manner to allow us to walk. Also ensures that the blood vessels and nerves on the sole of the foot doesn't get pinched when the person is standing up. And the shape of these arches is maintained based on the shape of the bones themselves, of the tarsals and the metatarsals. So we have 2 longitudinal arches that help to go along the length of the bone and foot and hold the bone up, and then a transverse arch going across the width of the foot, also helping to hold the foot up. And again, these arches are useful. All right, finally, we have some disorders associated with the foot. There's the bunion. Bunion is a localized swelling, often between the first metatarsal and the proximal phalanx 1, and that causes a distortion of that joint, causing the big toe to point inward. To point outward toward the second toe, and this is a somewhat painful occurrence. Then we have pes cavus, also known as clawed foot. This is where the longitudinal arches are excessively high, leading to the toes not ever actually having to touch the ground. So the clawed foot obviously adversely affects the distribution of weight. Then there's pes planus. Pes planus is the flat foot. Flat foot is when the medial longitudinal arch is flat. And then finally we have Talipes equinavarus. This is when the infant is born and the feet are pointing inwardly. This is also known as clubfoot. Basically, it occurs when there's not enough room in the womb and the feet are permanently inverted. And that is it for this chapter.